You know, baby just comes in not looking right. And so I want you guys to always think about some very important things whenever you see a baby or newborn or very young infant coming in with whatever complaint that just doesn't look right, either to you or to the emergency personnel or to a guardian or a parent or something like that. So that's where I'm coming from. I have no disclosures. So those are kind of my objectives, and I should have included them in the slides. They were included on your handout. But I'm going to really focus on the differences between fetal and neonatal circulation. I'm also going to focus on what you need to think of first, and think about this in a very systematic way. As many of you, if not all of you, already know, is what helps us especially in a crisis situation or an emergent situation or something that's very high stress, is if you have something that you can systematically go through. Because some of us, especially me, I cannot think of everything unless I have a sort of a routine or a system that I can follow, and that helps me to think of the important things and to not miss anything that would work. So in newborn emergencies, what do you want to think of first? And that's really what I want to talk about. When you have a baby that someone's brought in, and I'm going to go through one case review that happened to me personally a long time ago. But again, case reviews just help me remember certain things. One of the things I want you to always remember, even though we're here talking about fetal circulation and newborn circulation, whenever you have a newborn or very young infant coming in that doesn't look good or doesn't act right, the first thing you need to think about is infection. And I know that doesn't seem very exciting, although it can be very exciting. The morbidity and mortality of a newborn with a true infection is quite high. So I always want you to think, first things first, think of infection. But in spite of that, we're going to go through some other things that you can think of. And forgive me if this isn't very clear now that I see it on the board. Heart disease is certainly probably the next thing you're going to think about. And some of the reasons for that is that they can be very subtle. Babies can show signs of instability and being ill in ways that are subtle and not so subtle, but they could mean anything. So baby could have an infection, could have heart disease, could have a metabolic problem, and they could all look the same way, which is sort of can make you wonder, okay, how am I going to figure this out? But there are very, very clear steps that you can and should take as a triage nurse, an emergency room, that'll help you sort of narrow down and help you focus on the more important things that you need to focus on a baby. So some things to think about with heart disease. Shouldn't necessarily be the first thing you think about, but it should definitely be something in the back of your mind. Most congenital heart disease defects are not life-threatening. And even though some of them can be, most of them aren't. And most of them are picked up very early on if they are life-threatening. For instance, a baby with a true cyanotic heart disease, most of those will be picked up pretty early. So fortunately, they'll be picked up, if they haven't been picked up fetally on an ultrasound or some other pregnancy evaluation, they will be picked up pretty quickly after birth, sometimes even before they go home from their birth hospitalization. So just remember this, most heart disease defects are not life-threatening. Most are picked up very early on and dealt with very early on. So it's unusual for them to actually make it out of the hospital, go home, and go to the pediatrician even. And most newborns get to the pediatrician pretty early on in the first few days or week of life and end up in the ED with something life-threatening. It does happen, but it's fairly unusual.
Is it common now in prenatal care to do an ultrasound to identify any cardiac or any abnormalities?
In a nutshell, no. What is very common though, and is fairly standard in ultrasounds, especially that anatomy ultrasound that's done usually at about 20 weeks of gestation. So that's halfway through a pregnancy. And that point is actually fairly important because one, you're far enough along for most of the baby's organs to be very well developed by 20 weeks. May not be what we consider viable, but most of the organs are very well developed by 20 weeks. So that's one reason they choose 20 weeks. The other reason for 20 weeks is if, God forbid, that 20-week ultrasound shows anything very concerning, there is some time to do further testing, like genetic testing, further more detailed ultrasounds, even fetal MRIs, to figure out if this is something potentially lethal or not before, and given the option for termination of pregnancy. So that 20-week ultrasound, most obstetricians will recommend at least a 20-week ultrasound just to make sure everything looks normal. And as part of most standard 20-week anatomy ultrasounds, there's a particular view that's done of the heart. It's called a 4-chamber view. And that particular view can pick up most, if not almost all, very important heart defects. But it's not a fetal echo. It's definitely not an echocardiogram. It doesn't go into a lot of very big detail, but it should. If it's done correctly, a standard 20-week ultrasound will pick up major stuff in the fetal heart. So that's why that 20-week ultrasound is pretty important. Some pregnant moms choose not to have it. Some pregnant moms have it and nothing is seen on that ultrasound. It doesn't necessarily mean nothing is wrong or there isn't something there, but it will pick up most major things, especially cardiac things. But that's a good question. So we'll go over what a normal fetal heart looks like, and then we'll talk specifically about what changes happen once the baby takes its first breath, and once the baby is disconnected from the placenta. Some other things I wanted to bring up very, very briefly as far as emergencies in the neonatal period, and I wanted to at least mention them because I don't want to poo-poo them at all, because this can also make a baby come in and just not look good. GI emergencies. So we don't think of the intestines as an emergency, but it actually can be in a neonate. And there's some very, very specific things, mostly bowel obstructions, and they're mostly distal. If you think about it, if there's an obstruction higher up in the GI system, you'll probably notice it sooner. They'll throw up more. They'll probably have bilious emesis. So that'll be noticed sometimes before they go home from the hospital, or happen very quickly.
What causes a bowel obstruction in a neonate?
So that's usually an embryologic, the answer for that is usually embryologically based, because as you know, if you remember from way back when in anatomy, or if you ever took embryology, the intestine, the midgut, the foregut, the hindgut, all of that stuff develops very early on in the first couple weeks of gestation. And those tubes are designed then, and that's actually when we think the obstruction occurs. And because of that, it can lead to lots of different things. If, for instance, depending where the obstruction is, you can have a microcolon because nothing has gone through the colon during all of fetal life. So if depending on where the obstruction is, things can happen developmentally. So most obstructions we think happen very early in embryology, very, very early. So most of the time, if you have a baby coming into the emergency, I hope that answered your question. Coming into the emergency room that doesn't look right, and you think it's abdominal, it's usually a distal obstruction because this baby, especially if it's a breastfed baby, has been getting just a few drops, and as mom's milk comes in, gets a little bit more volume every day or so, and it's not until it's gotten enough volume for it to cause a problem, for there to be lots more emesis or there to be severe abdominal distension. So that's one of the emergencies that obviously has to be fixed. They can't eat if it's completely blocked. The other really big GI emergency that can happen in a newborn is a malrotation. So is it something we can pick up fetally? Not necessarily. It usually is not. It's rare for it to be picked up fetally, except the only time it can be is if we've for some reason done a fetal MRI and it's really good, it's in the right time of gestation, and they can see certain parts of the bowel and identify where they are, and if they're located in the right place.
What is malrotation? Does that mean like you're sending colons not in the right place, or you're sending colons not in the right place?
Good question. So everyone's bowel is fixed in a certain position, even though it's a tube that's sort of scrunched in there. As you know, your bowel is the normal length of an adult bowel. I forget how many feet. It's a lot, like 100 feet or something crazy like that. It's all bent up, but there are certain specific anatomical areas where it's fixed to the bowel, and if those do not become fixed. As you can imagine, it can twist in a certain way on itself, and that's what a volvulus is. Very, 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 very simply put, if it's not fixed correctly, it can twist on itself and cause an obstruction. Unfortunately, the obstruction can make a baby sicken. I've seen babies die from a volvulus if it's not picked up quickly enough. Intussusception, similar reason, it can cause an obstruction and make a baby look very toxic even, and come in, and they could be, those are emergencies, and they can literally go from the ED to the operating room for those kinds of presentations. So that's really why it's important that you at least acknowledge this abdomen doesn't look, not only does the baby doesn't not look right, but the abdomen doesn't look right as well. Inborn errors of metabolism is probably the fourth thing I'm going to talk about that can make babies just not look right. And I'm not going to spend a lot of time on this. This is, well, they each of themselves can be a lecture that's several hours long. So we won't go into this too much. Just know that it's rare, even more rare than heart problems in a baby. And there are only a few that will present in the newborn period, and I listed them there, like fatty acid oxidation disorders, organic acidureas, urea cycle defects, and they really, those three primarily can present in the newborn, early newborn period, and they usually present with a baby that looks ill. Remember, they can, all of these things can kind of look the same, and they have low blood sugar and ketoacidosis. So as you can tell, there are a few things that we can check very, very quickly in the first few minutes that you're seeing this baby, and certainly the minute you send any lab work, you can find out a lot of this stuff. What's the acid-base balance? What's the ammonia? And the first thing that I think any nurse can do on a baby that doesn't look well, other than the things we're going to talk about, is check a blood sugar. But we'll get to that. So normal fetal circulation. Let's get to kind of the heart of the matter. Why is this so important, and how different could it really be? Really, is it really different if you're growing in the mom's stomach than when you're out here? It actually is, and there's some very, very important differences. Boy, I wish this pointer worked. I might have to get up for this. So there are three big issues I want you to remember, and I'm trying to keep this as simple as possible. I don't think a lot of information is going to help you when you're trying to assess and triage a newborn. But I want you to remember three very important things as far as fetal circulation is concerned. One are the fetal shunts. So they're things that allow circulation to go a certain way, as you all know. You all know the basic kind of structure of anyone's heart. There are 4 chambers, and off of each chamber, whether it's an atrium or ventricle, there are lots of vessels, not lots, but big vessels that go somewhere. So as you know, in a fetus, there are certain fetal shunts, and I think you've all remembered them. One is a patent ductus arteriosus, we'll talk about it. One is a PFO, or a patent foramen ovale. One is the Ductus Venosus, we'll talk about that, and I'll show you where they are. So the most important thing to remember are fetal shunts. So they're fetal shunts that normally should occur in a fetus. And then those shunts need to go away. All those shunts need to go away normally for normal postnatal circulation to occur. And the problem occurs, or problems can occur, when one or more than one of those fetal shunts either don't close, or there's a defect that we really want the shunts to remain open so the baby can get even mixed oxygen. So we'll talk very briefly about that. Again, I'm not going to go into all the cardiac defects. I'll point out a couple, but I just want you to remember that the fetal shunts are normal in a fetus, and they will go away in most normal hearts once they're delivered. If there's a heart defect that a shunt will actually keep this baby alive with, we'll talk briefly about those as well. But again, I don't want you to focus on the specific heart defect. I want you to think about, if there is a shunt, should this shunt remain open or should it stay closed? That makes sense to you? So let's talk a little bit about fetal circulation. A fetus is relatively hypoxic, and you all know this because when every baby is born, they're blue, correct? That's a normal thing, and though it may freak some people out, but we all know that babies are born blue, And they're born blue because as a fetus, they're relatively hypoxic, and that's normal. And when I say relative hypoxia, I mean their PaO2 as a fetus is in the 60s and 70s normally. And as you know, that's kind of low for you and I, even for a newborn. So normal fetal oxygen levels are low. Why are they low? One of the reasons is because of the fetal shunts. And I'll go through the circulation of the blood, and the colors will help you kind of see where the oxygen is mixing and where it's not. But fetal shunts will keep the oxygen levels low because the baby doesn't need a lot of oxygen to grow and develop as a fetus. Remember that there's this huge organ that every fetus is connected to doing most of the work of oxygenation. It's the placenta. It's a powerful organ, and it's doing most of the work. So the baby's lungs do not oxygenate like yours and mine. It doesn't need to. The fetal lungs are filled with amniotic fluid. It's not air. There's no air inside the uterus at all, or inside the fetus anywhere, and it's all fluid. What's going on in that fluid in the lungs is a little bit of diffusion, etc., of fluid, and chemicals are shifting, but most of the work of oxygenation happens through the placenta as a fetus. It's not until we get rid of the placenta that the fetus is now a newborn, has to do all of that on their own. But primarily as a fetus, so the fetus has fetal shunts, the fetus is relatively hypoxic, and there's very little lung perfusion in a newborn. It doesn't need it. It's full of fluid. It doesn't need to really do most of the gas exchange. So the blood doesn't need to go to the lungs. Yours and mine, they better go to the lungs or we're in trouble. As a fetus, 95% of the blood flow is shunted away from the lungs. The lungs only get about 5 to 10% of cardiac output. Yours and mine, it better be the opposite, right? But the fetal lung does not lead a lot of blood flow because that's not the job of the fetal lung, okay? So let's go over circulation very quickly so we kind of get it in our mind. So this is where the placenta is attached. An important organ is doing a lot of the work. And if you remember as well, one of the only times in anatomy, human anatomy, where deoxygenated blood flows through an artery is the umbilical vein. So always remember that. And oxygenated blood is in the artery. Sorry, the other way around. So deoxygenated blood is in the artery. Oxygenated blood for the fetus is in the vein. It's the only time where that is switched. Every other time, as you know, arteries should carry oxygenated blood and veins carry deoxygenated blood. But this is the time coming from the placenta where that is the opposite. So from the placenta, remember the placenta is doing all the work. And it is sending through the vein all the nutrients and oxygen, whatever it needs to send, into the fetus through the umbilical vein that goes through the ductus venosus. And the ductus venosus is right next to the liver, right next to the portal circulation. So this is why if you ever worked in the NICU, we talked about the umbilical veins always getting caught up here in the liver, maybe causing damage. We're trying to get it through this channel called the ductus venosus into the IVC, close to the RA. So this is very important. This is a fetal shunt. This will go away, but as a fetus it's necessary because it's getting blood from the placenta to the fetal heart. So it goes in through the IVC, passing through the shunt into the RA. So here's the second shunt. As you can see, there's almost like some streaming. This is oxygenated blood from the placenta. It's red in the vein, IVC. Again, this is the only time this happens. It goes into the right atrium, and most of that blood coming from the IVC shoots straight across into the left atrium. This does not happen after, and this shunt, this path right here is the PFO, patent foramen ovale. So this is another shunt, and you can see it looks like a flap because that's what it is. And it's only open because pressure here as a fetus is higher than pressure in the other atrium, so it keeps it open. So blood easily goes from this atrium to this atrium, all the way here. Again, this blood is all red. It mixes here down into, now we're on the left side of the heart, comes out the left side of the heart into the aorta, and then goes to the body. So what happens here? Here's another shunt I want you to show, because I'm going at it from this direction. After birth, we have to think about it the other way, but we'll get to that. So as you can see, there's a shunt here, the patent ductus arteriosus, the PDA. I'm sure we've all heard of it. That can cause a problem after, but as a fetus, this is all normal. Some of the blood also mixes and flows through here. Now, most of the blood definitely goes down through the body, back to the placenta. Goes through umbilical arteries, and it's heading back to the placenta. Now, this is all oxygenated blood, and you're wondering, where does it get to the lungs? Remember I said, most of the blood doesn't need to go to the lungs. The lungs are filled with fluid. There needs to be some perfusion, because you need to deliver some nutrients and oxygen to all the fetal tissue so they can just grow and develop normally. But most of it should not go to the lungs. Most of it's bypassed the main pulmonary arteries and goes through this PDA here. And that's why this blood here, some of this blood does go down here from the right atrium into the right ventricle. It does go down, because as you can see, it comes from the top of the body into the right atrium, mixes with this oxygenated blood that comes in from the IVC into the right atrium. It does get down here, but that's why it's not the same color. So it's mixed deoxygenated blood and oxygenated blood coming into the right ventricle, out through the pulmonary artery. Some of it goes to the lungs. This is the right artery, left pulmonary artery. Most of it goes out through the PDA, joins the aortic blood that's oxygenated to the body. So we talked about 3 big shunts as a fetus. The first one is the ductus venosus, from the placenta through the hepatic circulation. We talked about the PFO, where most of this blood from the right atria can shunt through because pressure on this side is higher. And we talked about the ductus arteriosus. I know, I wish I had a pointer.
No, you're doing great. So this part here in the right atrium and this this communicates here from this vessel here and the right atrium.
This is all mixing. It's not the greatest, but you see this arrow right here?
Yeah.
This is all mixing here.
Okay.
So some of the blood goes through here, through the PFO. Some of the blood comes down and goes here. And that's why this is pink and not as red as this.
Okay, that makes sense.
Yeah. Any questions? I wanted to keep that as simple as possible, because really the important points are just those. So let's talk about what happens after the baby's born. So a couple very important things happen at delivery. Wherever delivery occurs, however it happens, whether it's vaginally or by cesarean. A few things have to occur normally. Well, they don't have to, but if they don't occur this way, you can have problems. One is the placenta's cut. And that may or may not happen before the first breath or not. As some of you may have heard of delayed cord clamping. That's now fairly well studied to have some benefit for certain populations of newborns, especially preterm babies. But no matter when it happens, the placenta, we have to get the placenta out of the equation. It has to, otherwise you're still a fetus. So you come out of the womb and you cut the placenta. One of the biggest organs in this whole process is now gone, and that is when this all has to occur now by the baby. The baby has to do it all. The placenta's not doing any of it at all. The baby has to do all of it. So lots of things happen structurally, biochemically. Those are the big things. And one of the ways you can think about this is, when the placenta's cut, the physical act of cutting stops this circulation we talked about. So it stops this. So nothing's coming here, correct? Nothing is going through this shunt anymore. The other thing that happens is the baby takes a breath, hopefully. If the baby doesn't do it, then hopefully someone will do it for them. But the lungs have to inflate with air. And that breath, or those breaths, do many, many things. And I'll talk about some of the big things they do. Is the more obvious things is that that breath is at least 21% oxygen. More if the baby needs more and someone can supply it, but it has at least 21% oxygen or room air. And that breath is displacing fluid. Remember we talked about the fetus is full of fluid, there's no air anywhere in the intestines or the lungs or anywhere else. So that fluid now has to be displaced by air, by the breath. Most of that fluid is not squeezed out through the mouth like most people think. Some of it does gurgle up maybe in the back of the throat. Most of it is absorbed by the displacement and the pressure of the breath by inhalation. So that fluid has to be displaced because obviously we are actually designed to diffuse molecules of oxygen, CO2, not fluid. So at least postnatally. So once that fluid is displaced, that's when ventilation, perfusion can happen in the lung. And stop me if any of that is kind of confusing. So remember, the fluid has to be displaced. Most of it is absorbed by air. Preferably nice big breaths. So the whole point of getting a baby to cry at birth is simply making them take large volumes of air. One, to displace the fluid that is in every fetal lung. Two is to establish PEEP. So end expiratory pressure, as you all know, is extremely important. Otherwise, we'll all have collapsed lungs, and we don't want that in any baby. So all of that breathing and crying helps to displace fluid and establish PEEP for that baby. So those are the two big things I want you to remember. The other things I want you to remember that happen very, very quickly is the act of cutting the placenta or disconnecting the placenta releases in the baby many chemicals, catecholamines especially, that also allow this process to happen. I want to use this, but I can't. And the process is the closing of the fetal shunts. Remember I talked about their fetal shunts because they have a purpose for the fetus. They're usually no good to us once we're out of the womb. So the fetal shunts have to close. Most of them don't close right away. So we'll talk about the fetal shunts. So we talked about, I got back with fetal circulation. That's more like it. So this one, as you know, this was coming from the placenta. It's now going to start shrinking because there's no flow through it anymore. Right. The placenta's not putting any blood. There's no pressure or anything. So that's going to slowly go away. It's still there, but there's nothing in it. It's not going to have a lot of flow. So this ductus venosus that was bypassing the portal circulation is going to eventually go away. It actually takes a little time, but because there's no flow in it, it's not usually, doesn't cause much problem. So this blood, since there's no oxygenated blood coming from the placenta anymore, this blood now is blue. Because it's coming from the body. It always was coming from the body, but as a fetus, it was a little bit more oxygenated because there was this shunt bringing oxygenated blood from the placenta. So now it's all blue because it's coming from the tissues, especially the lower body through the IVC. It's all deoxygenated blood going to the right side of the heart. So this is now all going to be blue. The other thing that happens with the breath, the third important thing that happens with your breath is that you increase right ventricular pressures. And that's extremely important for lots of reasons. You increase the pressure in the thorax with your breath, and that helps to increase pressures on the left side of the heart. And that alone, increased pressures in the left atria are extremely important. It closes the shunt. Remember, it's just a flap. So pressure and the blood goes path of least resistance everywhere, especially in the heart. So pressures here have to increase to close this shunt. Otherwise, they will still be mixing here. And there's sometimes that happens in some babies, especially if they have a large ASD, and that's part of how cardiologists diagnose an ASD, is if this flap cannot close, if it's too large to close, and blood still mixes on this level.
So that's where the atrial septal defect occurs, and they have to come back sometimes and ligate it or something?
Correct. So if it's a true PFO, so there is a difference anatomically between a PFO and an ASD. Part of it has to do with, is it a flap or is it just a big hole? So if it's a flap, it's made in the correct way and it's lying in the correct way, this should naturally close. It's not permanently closed. If for some reason pressure increases on this side, blood will shunt, path of least resistance, always. But LA pressures have to increase on the left-hand side. Cutting the placenta, catecholamines, that breath will help to do that, and it will close this second fetal shunt.
Also, in terms of just a time frame, you cut the placenta off, and then the baby is so it's very important they take their first breath to get that fluid out. Is there a time frame in terms of if they're still blue, like after 15 minutes? I mean, what is the normal time frame one could be looking at this newborn that where the placenta was cut and being delivered? I mean, how much of a time leeway do you have? And then you start realizing there's complications.
Yeah, they're not adapting or transitioning. We use the word
transition.
transitioning.
Is not as good as it should be. Maybe
Right.
your fetal shunts are not completely closed off.
Closing
How do you
well.
assess that?
By your saturations.
Okay.
So someone somewhere took on a research project and looked at in a normal term babies, what are their saturations at 1 minute, 5 minute, 10 minute, 50 minutes. And actually part of NRP, which is the BLS of newborn providers, it's called Neonatal Resuscitation Program. Some of you have probably taken it. Part of that now is we have a very nice chart that a lot of delivery rooms place on their wall by the bed that you're resuscitating a baby. At 1 minute, sat should be this. Normally, at 5 minutes, sat should be at least this. So that's a very good question, and people have actually looked at this so that people who do NRP and go to deliveries of babies should know this. Not necessarily by memory, but at least should have access to this information. By 1 minute, a normal baby should transition and their saturations, and I should say their preductal saturations, we'll get into that later, are perfectly okay, 65 to 75. That's still okay. If they're breathing, they're doing all the things they should do, and that's what people who are there to help babies at birth should know, and that's what they help them do. If they're breathing, fine, help them breathe, suction out their mouth, make sure they're getting warm because they come out wet and they get cold easily. So all those things are very important. By 5 minutes, most term babies should be probably above 75. I think by 10 minutes, I think it's above, should be 85 to getting into the 90s. And that's all normal. Totally normal. And it's good to know what is normal so that you don't freak out if a baby at 1 minute of life is still blue. They can be. And that's probably okay. But, somebody should watch them and make sure they don't stay blue.
So you say to get them up there to make sure that perfusion is good, that suction the nose, wrap them, keep them warm. Also stimulating,
Yes.
the whole big controversy about hitting them and slapping them.
We don't hit and slap anymore. No. Yeah, there was a controversy.
Rubbing the baby,
Stimulation,
stimulation
yeah.
to help increase the oxygen.
So you're
perfusion.
stimulating them for a couple reasons. One, to keep them crying. The family, the parents may freak out. A lot of them would say, "Why is he crying?" We actually like them to cry, and you have to reassure them it's actually okay. They're opening up their lungs. They're taking deep breaths. We actually want that to happen. So the breaths and drying stimulation helps that, as well as drying them off, because you also don't want a cold baby. And that's something to also remember when you're looking at a baby in the ED that doesn't look right. Is he cold? Babies who are cold don't look good. They look all mottled and pale, and their hands and feet are cold, and they may not like that. So cold babies are never very happy babies, and that's true in the delivery room. So that's a good point. So stimulation, them making sure that they're taking adequate breaths themselves, and we are of the mindset that if they're doing it themselves, they should not get any help from us. If they're doing it effectively themselves, and we have ways to evaluate what effective ventilation is or not. So we talked about all three of the fetal shunts. Any questions about fetal shunts and what happens when they go away? Any questions?
So what's with this patent ductus arteriosus? I mean, when that one goes away at the top.
So this last shunt, thank you for bringing it up. The PDA, unlike...
Because that's the one I always hear people say, like, is PDA getting closed? Is PDA getting closed? And I'm like, well, what does that mean to me?
Great point, and we'll get to that. The reason why, there are a couple things. One is that the PDA probably is the shunt that stays open the longest, takes the longest to close. So unlike the ductus venosus, there's no flow through it because there's no placenta, right? Unlike the PFO that closes just because there's more pressure. So it's not usually a big problem if there's normal transition. The PDA, though, does not close at birth. Most PDAs take days to close. What you want is the flow to decrease or go away very quickly. And what changes, remember, path of least resistance. So you want increased pressure on this left side, remember that, and oxygenated blood to go down here through the aorta. And you also want decreased pressure in the lungs. When you take your big breath, one of the big things that breath does is anatomically drops vascular resistance, helps dilation by increasing the oxygen levels. Oxygen is a vasodilator. It'll increase your pulmonary vascular, it'll decrease your pulmonary vascular resistance by causing vasodilation in the lung bed. And that's what you want. That drops the pressures in the lungs significantly. And that happens very, very quickly. It's a sharp drop in the vascular resistance in your lungs right after you're born. There should be. Sometimes that doesn't happen, and then you get persistent pulmonary hypertension, and babies get really sick and go on ECMO. That's the bad ones. But sometimes it can be very mild. And how you know that is because their SATs don't come up very quickly. They still have respiratory distress. They need oxygen for a long, long time because their pulmonary vascular resistance doesn't fall as quickly as we normally like to see it. So they continue to shunt here and mix blood, and that's why their SATs don't come up as quickly as a normal baby, because they're still shunting through their ductus venosus.
In the ER setting, if you have a neonatal, is it prudent to, I'm looking at interventions, you stimulate, you do this, you section nose, to slap on an intranasal, prong to give oxygen? At what point would you do that, and how high would you give? Is that being too premature, but at least getting oxygen if you have a child, an infant who is still very blue? I'm always wondering, at what point do we intervene? Or do we wait, like you said, 1 minute they should be this, 5 minutes that?
So you're talking about a baby who's delivered in your ED?
Well,
Yeah,
sometimes
we
our
have that
babies
happen.
deliver out in the
It can
field.
happen in any emergency room, can it?
It's uncommon in ours, but
Yeah.
it does happen.
It absolutely can happen. So that's the thing to remember. It doesn't really hurt to put some blow-by on a baby that you don't think is picking up fast enough.
Oh, bye, okay.
But just remember, and this is I'm going to go over some of the steps that are very similar to NRP. For a baby who's just come out and someone's cutting the cord and someone's running to get some warm blankets, dry your baby, because that does two things. It dries the wet off because you want them to get them warm as soon as possible, and it stimulates them to cry. If you have a baby who's screaming, that's what you want, whether they're blue or not. If that baby doesn't turn pink in 5 or 10 minutes, then you can talk about a problem. What I would do first is make sure you have a pulse ox on. Just put a pulse ox on, so you know what's going on.
And don't freak out when they're 65 and 70 at 1 minute and 5 minutes, right?
Correct.
Okay.
So before I do that, I'll put a pulse ox on the right hand always, if it's available, usually it is. Just put a pulse ox on the right hand so you can monitor things. As soon as they're born, because you're not quite sure, something the lighting isn't too bright or it's fluorescent, it's hard to tell, the baby's still cold, just put a pulse ox in while you're drying them off and getting them to cry. If they're not crying or you don't think they're breathing, then we have to go down a whole nother.
Why the right hand?
So great question. So let's take a look. Again, I wish this was working. So coming off the aorta are these three big vessels.
Sure.
And this one they're all going to the top of the body. That's how the top of the body gets everything. The descending aorta gets everything from below the chest, correct? But your head, your brain, and everything above the heart, oxygenated blood has to go through here. This vessel here, and forgive me, the name of this one completely escapes me, is what feeds the right side of your body. This one feeds mostly the left side of your body. But you will notice they're almost all preductal.
Oh.
You see where the duct is, and this is the position where most ducts occur, is right, it's usually right after these three vessels. Once in a while, the position is a little bit over, and it might be right here in the arch, or right here, but always the right hand is going to be preductal. The left hand is usually preductal as well, but there are a few times when the duct just comes off in a certain location where it's possible that the left hand might be postductal and not get as oxygenated blood as preductal if the duct is still open. So that's why if you want to be always preductal, you always do the right hand. So
Because
if you're
preductal gives you the best oxygenation the baby's going to have, right?
yes, the preductal will give you what is coming off of the aorta.
Okay.
Almost always what's coming off the aorta. So whenever somebody wants pre and postductal, whether it's blood pressure or saturation, you want right hand always, whether it's a blood pressure or saturation, in any leg. So forget the left hand. You don't need 4 limbs. You actually don't. Even though we still order that sometimes, you need a right hand and any leg. You really just need the 2. So it's also a quick thing to do in the emergency room. You're worried about a baby coming in not looking right, their SATs are not right. Make sure, especially in the newborn, anytime in the first week of life, get the right hand and try and get a pulse ox on any leg and a blood pressure on the right hand and leg. And this is why. It's simply because of this duct. Is it open? Is it closed? And you have a ductal dependent lesion and the baby is now shunting. And when we say shunting,
Coarctation issue, right?
it could be lots of things. Coarctation is certainly one of them that can create a huge difference in pre and postductal SATs. I've actually seen coarctations with no difference in SATs. So it may or may not be that. But if you have a ductal dependent lesion and you have a duct that's closing, then the baby might get into trouble. So you might have normal-ish preductal SATs and postductal SATs because the duct is now closed, it's not getting that mixed blood that it was depending on for whatever reason, and now their SATs in the lower extremities or lower body are very different, much lower. So that's an easy, quick thing for you to do on a baby that doesn't look good. We'll talk more about that. I'm gonna try and keep moving. So this is just a comparison for you to have if you have this, do side by side. This side is fetal. You immediately know which is fetal because you have red blood in the IVC and coming from the placenta, and there's blue blood now on the right side. With the first breaths, I think we talked a lot about this already. The fetal shunts close. Remember, all fetal shunts close. They should close, otherwise they're not really fetal shunts. You need more blood flow to the lungs. Now that fetal blood flow, which is maybe 5 or 10% of cardiac output, needs to reverse that. Now you need to have most of your cardiac output, at least output from the right side of the heart, go to the lungs. So that needs to happen. More oxygen then, of course, leaves the lungs back to the heart and back to the tissues. Your RV pressures must fall in order for the left-sided pressures to be relatively higher and close that shunt. And of course, blood goes to the path of least resistance. So this helps blood to go to the lungs if your pressures fall in the lungs. And you need to have increasing LA and LV pressures. Those kinds of things, if you just kind of think of blood, fetal shunts must close, pressures on the left side of the heart must increase. That's how you get more blood to the lungs. Those are kind of the basic things I think you must remember. So what are the first things you really should do? And we all know the ABCs of BLS. I don't think they call it ABC anymore. What do they call it now? Camp, that's right, camp. But we'll go back to the ABCs. So someone added a D. So airway, breathing, circulation, D is dextrose, and I keep bringing this up. So blood sugar is super, super important in a newborn, especially one that doesn't look good. We'll talk about it. Airway, it seems very obvious, but I'm sure you all know that somebody doesn't look good, you make sure they can breathe sufficiently effectively. You make sure their work of breathing, especially babies, they don't have the chest wall development that you and I have yet or older child has yet. So sometimes you can see them breathing. You should not see even a baby breathing. You really should be, you really have to peer at them to see them breathe. If you can easily notice them breathing across the room when you open their shirt or take off their whatever they're wearing, that is work of breathing, that's not normal. You should not notice or be able to see breathing. If you see it, there's either there are retractions of some kind, whether substernal, intercostal, if they don't have a lot of meat on their bones yet. So you shouldn't see them breathing. So you want them taking effective breaths. So you want to make sure they're lying in the right position. Sometimes if a baby is super small or doesn't have good tone, sometimes just lying in mom's arms can kink them over. So make sure whether their family is holding them or not, or they're lying on the bed, make sure they're in a neutral position. Make sure they don't have a lot of secretions, milk, whatever in their throat. So listening to them is very important. Make sure you can hear air flowing and that you don't hear gurgling or ronchi or ralls or anything like that. So you're going to listen for noisy breathing or even stridor. Babies can actually be born with stridor or develop stridor soon after birth. So listen, you shouldn't hear a baby breathe. You shouldn't see a baby breathe. They should be pink though. They should be breathing. But if you notice anything, you hear anything, you see things very easily, that's probably not normal. So airway is huge. So like we said, what type of breathing are they doing? Are they retracting? Are they breathing fast? So it's really important. You check your vital signs like you always do on anyone that comes into triage. And it's super important that you actually count for 1 minute. The reason for that is babies are periodic breathers. Term normal babies do not breathe regularly. You and I breathe super regularly. We can almost put a metronome to it. Newborns do not. They breathe and they pause, and they pick up and they breathe. Sometimes they breathe very fast and then they slow down, all within 1 minute. So their pattern of breathing changes a lot. So that's why getting a full minute count of respiration is actually very important. And not just looking at them for a couple seconds and saying, oh, they're tachypnic, or they're not breathing. They could be doing some periodic breathing. Pausing is normal. They shouldn't pause long enough to turn blue. And that's what we tell families too, because they're not counting at home. They don't have monitors at home. They shouldn't. But they should stay pink. So, but it's important that you count for a minute, and then actually also note in your documentation what type of breathing. Is it irregular? Does he have a lot of pausing? Does he have periodic breathing? You can note that as well. And of course, a very easy thing for you to do as well is just put a pulse ox on them, especially if you're worried. Certainly if they don't look quite pink, you're not sure if the lips are pink or not, just put a pulse ox on their right hand. Always in a newborn, just put it on the right hand and see what it is. And if you have a spare pulse ox, even better. And if you're worried, you can quickly document. It can just be a spot check. Quickly document at the same time what the right hand and the foot are. Document if they're the same. Probably okay. Leave it on for a few minutes, and then you can take it off if you don't want to have the baby doesn't want to have all that on them. But a right hand pulse ox documentation is huge. Circulation, of course, again, continue doing all your vital signs. Check the pulse, the blood pressure, and actually look at their color and skin. Baby's skin they can turn all kinds of colors. It's not just pink or blue. They could be pale. They can be mottled. I should have brought some pictures of some nice models. I actually have some old pictures of some nice model newborn. And some of it can be normal, believe it or not. But just make note of whatever you see. Modeling on just the feet or the legs. Modeling all over. pale all over, pale only on the distal extremities. Make note of color, temperature, touch them. My hand's always freezing, so I'm always touching, putting on gloves for that reason, but it's really important that you feel their temperature, their core temperature, so somewhere on their body, as well as their distal temperature, so their hands and their feet, and document that. That can tell you a lot of things. It could just be the baby's cold. The first part of their body to turn cool and turn mottled and pale are their extremities, obviously, but just note that and document it. And then if the temperature is cool, warm them up. Get a heat lamp, get some warm blankets, put them on their mom. If they don't need any help with breathing or anything else, put them close to their family or guardian, whoever brought them in. Body heat is a great way to warm a baby up.
Or the Ohio table.
Or the what?
The Ohio table.
Or whatever warmer you have. Yeah, absolutely. But if a baby just can't settle down, sometimes or a parent can't settle down unless they're holding their child, body heat is also actually quite effective too as well. So the fourth part of this is dextrose. So probably even before, and I don't know if you can actually do this in the ED. Can you check a blood sugar without an order in your ED?
Yeah.
Anybody?
I mean, yeah, we have, the machine will allow us, we just need a medical record number.
You just need a number. Perfect. I'm glad to hear that. Because I think that's one very important, very simple thing you can do with your vital sign check. A baby doesn't look good, you made sure they're breathing effectively. If airway breathing is a problem, you deal with that. Absolutely. If they're apneic, do whatever you need to do. Call everybody in. Make sure they're breathing. Make sure you have circulation that's adequate or being monitored very closely. And if all of that is checked, you have that under control, check their sugar. Every newborn should have their sugar checked in triage, I think. If they don't look good, they should have their sugar checked with their vital signs. Again, if they're breathing and all that stuff is okay. If you need to do other things, then of course all bets are off. So check that, and any blood sugar should be above 60. If you talk to an endocrinologist, they probably should be over 70, but it really depends. When did they last feed? And I don't know. Has it been 6 hours? Has it been 8 hours? I don't know, but it should be above 60. 57 is not okay in any newborn.
So no matter where you get the blood sample, fingers, heel, doesn't matter.
No.
Okay.
Is there something with our AccuCheck machines that they're not accurate under 30 days or something? What's that?
No, it's, the manufacturer does not recommend doing venous blood pressure, but blood
Oh,
sugars.
venous.
Oh,
Um,
I see,
and-
okay.
Yeah,
So we
otherwise
can
you
do
can do
skin, right.
capillary, you
Alright.
can do arterial, but
Okay.
venous is not recommended.
In the machines you're using. Okay, that's good to know, but capillary from anywhere is totally fine. And again, if this baby is in triage, you're not quite sure where things are gonna go, and you get them in the back and you have a low blood sugar, you need to talk to that with somebody about it. So that they're either gonna let you feed the baby or not feed the baby and put in an IV and go that route. So any low blood sugar needs to be dealt with right away. That's not something that can wait at all in a newborn. It's only gonna go down for the most part. If it's already gotten this low, you know they're already in trouble. Most babies can maintain, after the first 12 to 24 hours, should be able to maintain a normal blood sugar, even fasting for several hours. They have lots of brown fat stores all over. If it looks like a normally nourished newborn, so a baby that's appropriate for gestation age, all bets are off if this is a preterm baby. All bets are off if this is a small for gestational age baby, because they don't have the stores on them. That's part of the reason they're small on them, to keep their blood sugar normal. So it's even more urgent if they're small or premature to get on top of this blood sugar.
How if their mothers are diabetic and the babies are exceptionally large? Would that affect their circulating blood glucose?
Absolutely. Until they're able to regulate their insulin secretion themselves, there definitely will be. So we have a lot of babies in the NICU that are just IDM babies or infants of diabetic mothers because they have lots of circulating insulin. It's not their fault. They just have lots of insulin because they were just connected to a placenta that was giving them lots of insulin. It's hanging around. The placenta's going to hang around for a while. And until their pancreas starts to regulate that insulin and their own insulin, and maternal insulin levels go away, sometimes they need lots of sugar from us. So yeah, we have lots of babies in the NICU for that very reason. So immediately after delivery of IBM baby needs to be monitored super closely, and most nurseries have protocols for very frequent blood sugars for that reason, because it can be a problem. So blood sugar, blood sugar, blood sugar on anybody any newborn that doesn't look well. So this really happened to me. Several years ago, I was doing transport call, neonatal transport call at the time. So I got called to, and it's either to a clinic or to an emergency room, which is pretty common. So this was a newborn that was 2 weeks old, fairly uncomplicated pregnancy, delivery, went home. The baby was at the primary pediatrician's office for a routine well baby check. On exam, though, in the office, the baby was pale, tachypnic, he had a little bit of retractions, and he just wasn't acting right. He was drowsy, didn't want to feed that day very well. He had decreased appetite, and of course, they slapped on a pulse oximeter. Even in an office, an ED or pediatrician's office, they'll usually have a portable pulse ox sitting somewhere in case they need to do a quick check. It was okay, 88 to 91. This is a 2-week-old. That's not normal in a 2-week-old. So this is in room air. They send him, like I would too, straight to the emergency room. And I think that's where I met him. It's either in the pediatrician's office or in the emergency room. His abdomen was fine, because remember, any baby that doesn't look well, you want to think, not just heart problems, GI problems, metabolic. You want to really quickly think about all those things. His abdomen looked fine. He had been breastfeeding, other than the decreased appetite over the past couple of days. He hadn't been throwing up very much, just a little bit of milk. So what would you do first? Remember, A, B, C, D. Always A, B, C, D. A, B. So what's his airway? Is he breathing effectively on his own? Then you're going to take vital signs. You take all of them. Heart rate, blood pressure, respiratory rate for a full minute. What's his breathing like? How deep are the retractions? How tachypnic is he? Is he breathing 40 or 60, or is he breathing 100 to 120? Babies can do that. It's amazing how fast they can breathe. So you do a very quick ABCD assessment. And if you need it, for instance, if the blood sugar is low, you put that IV in. Please just put it in. And whatever is quicker, pulse ox, pulse ox, pulse ox. Anything non-invasive that you can do quickly, like slapping on some leads and putting the heart monitor on a pulse ox, that will be huge. Because one, it's continuous, and you can set alarms on it, which I highly recommend, that you can keep track of. You can set the alarms to go off for whatever numbers that you think are appropriate for a newborn. And I don't know if your emergency room have those kind of a protocol per se for alarms or anything that you always notify someone for. I don't know if your emergency room has that, but it's a great idea. So put a pulse ox on rapidly. If they don't look good, like their perfusion doesn't look good, their blood sugar is low, maybe they've had a couple dry diapers today, the doctor might say, just let's give them a fluid bolus and start there. And and that's okay. You give them a dextrose bolus if the blood sugar is low, a fluid bolus of saline, 10 or 20 mLs per kilo. That's a great place to start in a baby that doesn't look good. Great place to start. Reevaluate, reevaluate, reevaluate. So you go back here, every few minutes, whatever your protocol is, or however sick you think this baby is, reevaluate and document, for heaven's sakes. If you evaluate, please write it down. Take credit for it and make sure you're covered. So what else would you do? This baby that I'm seeing in the emergency room, his blood sugar is normal. They've already checked that by the time I get there. He's still barely saturating high 80s, low 90s in room air. So I slap a face mask of just oxygen from the wall on him, and I get him maybe a little higher, but not much. That kind of response bothers me. Most of the time, if a baby has just a respiratory problem, it'll respond to oxygen just blown in your face. Most of the time, even if it's a cardiac problem, you'll respond to a lot of oxygen blown in your face. The fact that this baby didn't respond very much to lots of oxygen, it's usually wall oxygen, so it's 100% flow, whatever, blown in your face, worries me quite a bit. So I slap on post-ductal sats, and they're no different, okay? So he has a PIV in, we've given a normal saline bolus, they've gotten a set of labs, and with it is an arterial blood gas, and that's what it is, 7